Hello, everyone. My name's Kildea. I'm one of the co-directors of the Molly Wardaguga Research Centre, and I'm talking to you today from Central Aranda Country in Midwifery in Alice Springs. And I would like to, before I begin, I'd like to acknowledge the fact that I'm here on Aboriginal land and that there's people from many countries being represented and joining us across Australia on land that has never been ceded. And I'd like to pay my respects to elders, past, present and emerging, and also to any Aboriginal or Torres Strait Islander First Nations people who are joining us today. Today's an exciting day. I'm really pleased to be introducing Liz Wilkes. I was trying to remember just before we started how long I've known Liz for, and I think it's since around about 1993, Liz, would that be about right?
That's right. No, yeah. That's right.
So it's about 20 years, if my maths is right. Is that right?
No, it's about 30 years.
No, 30 years. Definitely time I started thinking about retiring. Anyway, Liz has been a midwife since 1995. She's been in private practice for about 16 years, and many of you will know that she's established My Midwives as one of the largest private midwifery practices in Australia. Liz, from many years ago, has been an extraordinary midwifery leader. She's been very active in the College of Midwives. She's worked a lot on trying to get Medicare working in this space, and for anyone that has been involved and around for as long as me, you'll know that we are actually getting Medicare working quite well for midwives in a way that it hasn't really progressed as well for nurse practitioners. So that's some of that is to do with the intense lobbying and work that Liz and her team and other private midwives across Australia have done. She's had a lot to do with public policy development, business development, and she's got a Master's of Business Administration from Griffith University. She's been Vice President of Midwives Australia, and for us, Liz has been consulting for us and working on the Birthing on Country work for a couple of years now, and doing some really innovative stuff in Southeast Queensland, which she's going to talk to us about today. So really great to have you here today, Liz, and I'll hand over to you. Just before I do, if people have got questions, if you can put them in the chat, that would be great, and we'll try to get to them when we can.
Thanks, Sue. You've probably done most of my intro now, but I feel very pleased to be with you all today and talking on something that I feel so passionately about, and has been, a big part of my life now for a fairly significant period of time. I just need to get this working. So obviously, as Sue said, I'm the Managing Director of My Midwives, and I'm an endorsed midwife. And I guess that I recognise that people will have different levels of knowledge about this sort of idea or concept of endorsed midwives, and I'll talk about that as we go through the presentation. I've been working with CDU and on Birthing on Country for the last couple of years, and again, I feel very lucky to have been able to be involved in this. So I also, I'm coming to you from the lands of the Guyabal and Jarrah people, and I also would like to echo Sue's words. The land that we are on has never been ceded, and obviously, the struggles that have gone on over a period of time. I would like to pay my respects to the elders past and present of the land that I'm on, and also extend that respect to those of you that are present today that are First Nations people. So I just wanted to get My Midwives sort of stuff out of the way and who we are, because I guess that's a big part of who I am and why I'm here. We established as the first midwifery practice really to use Medicare in 2010, and every time I do this presentation, the numbers have increased. So we're up to now 33 endorsed midwives and 7 non-endorsed midwives, 5 midwives as directors, and we have clinics both in Brisbane and Melbourne and also in regional Victoria and Toowoomba. And I guess the main focus of this presentation is the last 2 points, which are around our partnership with the Institute for Urban Indigenous Health in Brisbane and the work that we're doing in their Birthing in Our Community model. And I suppose the extension of that into what we do with CDU and how that research and how that can be rolled out, I guess, or expanded on for other areas. And I think that probably this presentation will give you a bit of a taste of what that all means, but there'll obviously be a lot of depth that I can't cover. And I also don't know sort of, I guess, where everybody's coming from in their level of knowledge and understanding of these principles. Some of them are so complicated that Sue and I can have battles over days and weeks and months about particular individual pieces of legislation. So I recognise that some of what I say may be a little bit confusing and may need questions at the end of it. So at the state of Australian maternity care, I guess for most of you, you're probably focused on the too little and the too late bit, but I guess for where we sit, we also look at the too much too soon component of this, because we're really in a state in Australia where we've got both sort of polarities really, where we've got lots of things not being dealt with particularly well, and then we've got people intervening in maternity care often too much. So I'm going to touch on those. This is Sue's slide, so I've taken this from her work, and I guess that this is where most of you spend most of your time focused and looking at the great disparity and lack of equality for First Nations women. And I guess for me, the really stark contrast, even for women in the Northern Territory, is what's kind of brought me really more fulsomely into this space to look at what we can do to actually change some of these outcomes. Because I think that when we look at things like the perinatal death rate per 1,000 births, being at 28.3% for Northern Territory First Nation women, that is just diabolical. And I know you all know this part, but I think it's really important that we actually just look at the background of why we need to do things. And obviously these numbers as well, maternal mortality, they're comparing First Nations Australians and other Australians and preterm birth. And I guess that we don't want to stay in the negatives, but these are the things that we need to change. On the other side of the coin, though, we also have too much too soon. So that's not just for First Nations people, but it's also not excluding First Nations people. We have caesarean section rates that are off the chart. And I think even in recent times, looking at some of the work that CDU have been doing with Congress Alukra and examining perhaps what the experience of First Nations women in areas such as Alice Springs are, we can see caesarean section rates may even be higher in some of these areas. And I think that's diabolical. Like, we just can't sort of go on with things being quite so interventionist. So I think it's important that we get the balance of those things right, because obviously when we have a lot of intervention, we also have significant levels of trauma for all women. And last year, it's 2 years ago now, the largest Australian study revealed that 1 in 10 women were suffering from some form of obstetric violence. So, that's not okay. We have vast evidence of, systemic racism in hospitals, and particularly when we look at obstetric care and you put these layers one upon another, I think it shows that the picture is quite tricky and that we need to be doing better around it. But I guess I come from a glass half full kind of perspective. So I've given you all the bad stuff now so you can all relax, because I guess from here I want to look at the things that we have got and that we can do. And most of you will know that the passion around midwifery continuity of care for all women exists in me. And I guess these stats are really about that sort of continuity and what we can do in reducing things like stillbirth and preterm birth for all communities. And thankfully CDU are helping my midwives at the moment to analyse our data over the last sort of 8 to 10 years, and looking at where we sit in terms of those sorts of statistics. And the statistics are great. And so I guess that we want to just put layer upon layer of evidence really into what continuity of care can provide for women. So where this journey sort of started for me is as an endorsed midwife. And I used this slide on another presentation. I said to someone, can we have a slide that shows endorsed midwives kind of as a superpower? And this is what they come up with. And look, I don't actually think that endorsed midwives themselves are a superpower, because they're really just midwives, midwives that have done a little bit of additional work. And I'll talk about that in a sec. But I thought it was funny, because it is something that means that midwives can actually then be focused and working to a sort of more fulsome scope of practice in some ways. So I think we'll talk about that. So what an endorsed midwife is a midwife who is regulated by AHPRA. They have an additional endorsement on their registration. And basically the two components to that at the moment are that they've done 5,000 hours of clinical practice in the last 6 years, and that they have a postgraduate qualification in prescribing. Really, that's it. So there's not really much superpower in it, except what it then leads those midwives to be able to do. Now, there's really no evidence to either of these requirements. So firstly, the 5,000 hours in the last 6 years is somewhat restrictive, because obviously it doesn't take into consideration where midwives have got to go on to maternity leave, or they've got to take any other forms of leave. There's no sort of evidence really that demonstrates that there's any sort of specific number of hours that midwives have to do in practice before they can work to full scope. And so quite sort of limiting, and will be reviewed sort of within the next 12 months. So it's a good thing to see that it will be reviewed, and certainly in the last 6 years that needs to very much change. The other element to it is the prescribing as a postgraduate qualification. Internationally, midwives can prescribe in many other nations when they come out of their undergraduate qualifications. So I think it's sort of normal scope for plenty of places, and I think we need to follow suit. And the other thing is that we have a very limited formulary. We're not prescribing particularly complex medications, and we're not sort of in situations generally where there's a significant risk in anything that we are prescribing. It's usually things that are really within scope in terms of treating women. So the superpower bit is really what the endorsed midwife can do. So all midwives can provide primary maternity care across the full scope of practice. So that's not a superpower, but that is really, I suppose, focused on for an endorsed midwife, because that's predominantly what most endorsed midwives have gone into that endorsement to do. Obviously, there's different models that people are using now, but that was why this whole regulation was set up, was to enable midwives to work in primary maternity care. We also can have visiting access into public hospitals as the admitting clinician, which means that women that we are providing primary care to in the antenatal period are admitted to hospital as our private patients. And I'll talk about that component because it's the private thing that some people sort of grapple around with a little bit. This doesn't mean that they've got private health insurance. It means that they're being admitted under the care of the endorsed midwives. The other thing that we can do is order and interpret pathology, diagnostic imaging. We can prescribe, as I said before, and we can directly refer to obstetricians and paediatricians. And that also takes out sort of an additional step in terms of that consultation referral pathway. You don't have to go via a GP or someone else to actually get that referral through to an obstetrician. So it does make that pathway quite a lot smoother. Then the second to last one, Medicare rebates, is the thing that really where the rubber hits the road, and Sue alluded to that in her intro. It's quite a, an enabler, I guess, for birthing on country models to be using endorsed midwives, because it provides that additional source of funding. And I guess it is that direct funding that is particularly relevant to sustaining birthing on country models. Now, look, we know that Medicare is not particularly well suited to continuity of care models because it's fee for service. And there's a whole nother topic in that around sort of what we call bundled funding, like bundling together parts of the continuity. That's something that we're now really working on, lobbying and advocating for, and have been for the last few years. because it's really important that we get sort of a better idea around providing the maternity care in those sort of continuous bundles. It's also not there's no birth outside of hospital, and that's problematic at the moment for birthing on country models, because we're unsure about, you know, how that will impact that sort of expansion of the model to be allowing women to birth on country or at home, and also to be considering sort of the primary birthing units, or even birthing units that can be set up that are outside of a sort of hospital structure. So I'll just chuck these figures down the bottom rather than leaving that there. That's the number and sort of math around Medicare rebates. It's an incredibly busy, ridiculously busy slide. But I guess what's most important is the approximate income that can be produced for a caseload midwife and the various numbers associated with that. That's at the bottom of the screen. So as you can see, I suppose I didn't explain what caseload is. I'm hoping that you have a little bit of understanding about the basics of caseload care. So midwives working in continuity of care models provide care to women in a caseload model. So they're looking after a set number of women per annum. And in models that are working in birthing on country space, usually it's reduced down from sort of what's the normal level of 40 women per annum down to a more sort of manageable 28, 32, that sort of level 30, maybe even starting at a slightly lower level than that to resolve some of the complexities that are associated with women that are working in birthing on country models. So if you can look at the bottom there, you can see that they're the sorts of numbers that you can generate, or the revenue you can generate from a caseload of 28 women, 32 women, or 40 women per annum. And whilst that doesn't cover obviously the cost of the model or even probably the midwife's salary, it does provide you with a bit of a backup, a bit of sustainability around the model, and is feeding sort of some funds, ongoing funds into the model that are outside of grant funding or any other sorts of operational funds. So it does provide a bit of a foundation and an ability to actually plan past that sort of generalised grant sort of cycle. You can see that there are a few different items there. We're working on more. There's been more items that have been accepted through the Medicare task force process that have yet to go through a budget cycle. Things like admitting women to hospital and being able to provide care to women for extended consultations, both in the antenatal and postnatal period. And we're fairly hopeful that that they at some point will be going through a budget cycle and will be accepted by government and implemented in the next sort of short period of time. So how my midwives and BIOC sort of got together, we'll have to consider some of the background. So this is part of our team and where they're sort of located at the moment. But obviously the work that was done prior to us joining BIOC is what is the main tale. The Indigenous Birthing in Urban Setting study, which obviously most of you are probably aware of, but that Sue and the various teams within IUE and Charles Darwin and the Molly Centre at a later time conducted over the last few years are based on the partnership between the Institute for Urban Indigenous Health, the Mater Hospital, and various other partner organisations. It was part of an NHMRC partnership grant and demonstrated a reduction in preterm birth of 38%. So that model was being run on the south side of Brisbane. So the Birthing in Our Community model there has been in existence now for nearly 10 years. Is it nearly 10 years, Sue?
Correct. They've got their 10-year anniversary coming up very soon.
Yeah, I thought it was. So that model was already in existence and demonstrated amazing outcomes on so many different levels. We then, and obviously then it is expanded, and there's been a look at how the model can be then broadened out. And Rise in Action at BIOC, this is an IUE slide from Christy Wardaguga, that she used at the recent Best Start to Life conference. There's basically the 4 different components to Rise in Action, and that is, as you can see there, basically the redesign of the health system, investing in the workforce, strengthening families and embedding in community. And at BIOC, there are a range of different ways that Rise is in action at BIOC. And I think that we sort of came along, well, actually, I'll just go back to Sue. So Sue had approached me to give some advice as to how endorsed midwives could work in the framework of birthing on country. And I started to sort of examine what were the ways that endorsed midwives, mostly from a financial perspective, could work in this model. And the other component to it was that there were some problems in insurance issues for the birthing on country models. And Sue invited me to attend a group with the Commonwealth. Adrian Carson, as the CEO for IUE, was on that group and heard the conversations between myself and the Commonwealth and Sue and various other people, and thought that there might be a partnership opportunity between my midwives and the Institute to help in resolving some of the expansion of the birthing in our community models. So the really brief version of it is that we had a few meetings, and this sounds pretty simplistic, and this is exactly how simplistic it was. We had a few meetings. We looked at our values, and on the left side are the values of my midwives, which are excellence, innovation, service, resilience, and team. And then looked at the ways that IUE as an organisation worked. We recognised that there was a really significant alignment with how we viewed the world and what our goals were in terms of care, my midwife's goals in terms of care for women in general, and obviously IUE's goals in terms of expanding BIOC into the various communities in North Brisbane and beyond. I won't go into why IUE had felt that they needed to approach a separate organisation, but if we go back, and I don't know whether I'm going to be able to go back, I hope I will. Yep. But if we go back to here, one of the things that was really fundamental was the fact that having an organisation like my midwives that was outside of the hospital setting meant that the ability to have Aboriginal governance and control far more embedded in the model was possible, because you weren't actually looking at a hospital employed midwives. You were looking at midwives that were already outside the system and were therefore able to basically work in a joint or a shared way of governance between my midwives and the Institute for Urban Indigenous Health. So the midwives in the BIOC model, the endorsed midwives, provide the services for the women, and that's in place of hospital employed midwives. So they are able to then admit the women to hospital under the care of the endorsed midwife and do all of the things that we've been doing in provision of care for the last 10 years. So we prescribe, order, interpret, pathology. We provide care, importantly, we provide care to women at all levels of risk. So it's not about providing sort of low risk maternity care. It is about every single woman, and we can work in collaboration with the obstetric, paediatric and other multidisciplinary teams. The big thing was obviously that the Medicare rebates assisted in this case, IUE, to fund the midwifery care, and that the midwives are engaged by community. So they're directly really in partnership with a woman rather than via a hospital, which further embeds community control. Now, I do want to note that in this particular model with my midwives, the midwives are not employed by the ARCHO, but I guess that's taking it yet another step further. And certainly in models like Waminda are implementing at the moment in Nowra, that's taking that next step into complete community control. So the midwives themselves are working alongside and learning from MOB. So they go through the full cultural integrity framework with IUE, learning the ways. The partnership with my midwives is absolutely critical. So we have representation on both so both IUE are represented in any meetings that we have, and we are also involved in any meetings that they have. So it is a true governance arrangement that partners with between both the organisations. So we have things like the interview panels for the midwives. We have IUE team members involved intricately in those, and vice versa. We also have a midwifery manager who is a director of My Midwives, who had existing relationships with the hospital system in Metro North. And part of the reason why this was a smooth, easy, I'm sort of talking about this model as being, you can do it, it's utopia, you can do it so quickly. Well, the reason is that there was sort of 10 years or nearly 10 years of background of Karen having had, who's the director that's in the blue shirt in this slide, having had relationships as a My Midwives director in Metro North, and then prior to that for about another 10 years or 15 years as a midwife in Metro North. So she knew everybody within the Metro North framework. So she is on site in the Strathpine Clinic, which is the clinic that you're in, that you can see there, with our team and with the IUE team, and she's available to sort of troubleshoot any of the both clinical and administrative pathways with things like Medicare and insurance, so that the team can actually focus on doing what they need to do, and the relationships between the midwives and the rest of the IUE team. So there's ongoing clinical supervision within IUE and within My Midwives. I developed risk management framework and access to cultural supervision. Now, all of the midwives are participating with everybody in the community days and social events. And in fact, that's sort of integral to the relationships between all of the teams. So this is one of the statements that was made, which it's more than continuity with a midwife. Continuity of care is the gold standard. BIOC is platinum because of all the different specialties and support services that are wrap around the mum. So I'm just going to give a very brief overview of a case study here, which is just a little tiny taste of some of the complexity. Leigh and Dion have given permission for their case study and their pictures to be shared. Leigh was a first-time mum who had a very, very complicated history of epilepsy, diabetes, intellectual impairment, and mental health problems. She engaged with BIOC. There was collaboration between the obstetricians and medical obstetrics care, and she was transferred to tertiary care but remained part of the BIOC model with her midwife, more importantly, her family support worker, who walks alongside the midwives. And I'll go back to that in a minute, but I'll explain the role of the family support worker with the midwives in a sec. Psychologists, OT, transport, and the social worker, and of course NDIS, who are already involved in her care. Now, she ended up having a cesarean section because she had quite significantly deteriorating health and was in hospital for 7 days. But the team had organised for Dion and Leigh to be supported in hospital, for Dion to stay with Leigh and for them to have intensive care with their family support worker and midwife while they were in hospital. There were some child safety concerns, particularly around Leigh's mental health and also her intellectual impairment, and concerns as to whether she would be able to care for baby Jordan well at home. But that case was closed before they even left the hospital, which was absolutely amazing. And we continued to follow them for 6 weeks and transitioned the family's care through to the GP and child health nurse. And the family support worker is still involved with the family. Now, I think the thing to look at here is the intensity of visits. There were 13 visits in the antenatal period and 22 phone calls. And in the postnatal period, there were 24 postnatal visits and 15 phone calls. Some of those postnatal visits were quite extensive and long, but there was an ability to actually flex that midwife's workload up and down as a result of the intensity that she needed to provide this family in terms of the care. And I guess that the thing for me is this family would have had a very, very different experience had they not been involved with this program. I know from the conversations with child safety at the time in particular, but even with the NDIS, that it was the ability to spend so much time with Lay in the period of the early postnatal period in helping her to recognise her position in the world as a mother, the support of the family support workers and the extended IUE team in enabling some of the wraparound supports like housing and transport, which were a massive deal for this family, and were resolved as a result of the intervention of the IUE team. And that sort of option is just not, mainstream services do not provide these sorts of really, really intensive levels of support. But if we actually look at what the savings are then for this family and what then has happened to this little person, you can see him climbing here on Mum on a community day down there with Lay's in the pink shirt and Bubs on top of her. But this is now, we've got this picture's quite old, but we've got pictures of him and the family participating in community day ongoing for an extended period of time. And they've been able to stay together. They've stayed together and actually working through, and that has been, I think, really a credit to this entire team. So when we talk about the E and being embedded in community, the whole team works together and are part of a group, really. And I would say that the family support workers and the midwives work in a unique kind of partnership. So they work alongside each other. So when in other continuity of care models, the midwife and the woman are in a partnership, in this model, it's a three-way partnership. The family support worker's role is as important, if not more important, than the midwife's role. So the midwife is actually providing midwifery care, and the family support worker is ensuring that the entire model is really wrapped around that woman and supporting that midwife and ensuring that her the way that the midwife is providing the care is culturally embedded in what community want. So the midwives in this particular model, my midwives team, are not First Nations midwives. Sorry, that should be capitalised there. But anyway, we're not First Nations midwives. We are based in the Archo setting and they're working from there every day. They are employed by my midwives, but they have that joint governance structure that I spoke about before. And obviously, as I said earlier, the next step in that model is to be able to have the midwives actually employed by the Archo. So how do we scale this model? Well, every Archo has the opportunity to use this model. Primary maternity care is very well suited to models outside of the urban setting. So this is in an urban setting. It's actually better suited almost to rural settings and remote settings because there are midwives still able to be there. The structure exists. Financially, there's assistance to make a sustainable model. And goodness, there's some spelling mistakes in this. They're going on to the barriers. There is a structural barriers paper that outlines some of the issues that are still around, that are still a problem, and that's currently under review. But the main barrier that I guess I want to highlight, or the two main barriers that I want to highlight, are the number of endorsed midwives in Australia. If we look at this little slide here, we can see that there's getting towards 1,000 endorsed midwives at the moment. To make it financially viable, the endorsement model is really the way to go in terms of Medicare funding, but we need more endorsed midwives. If we look at the trajectory that, say, nurse practitioners took, we are on a quicker trajectory to increase numbers than they have done. It's taken them nearly 20 years to get to 2,000 midwives. We look as if we're doubling our midwives essentially from about 2017-18, we have doubled the number of midwives, and we look like that's actually going up sort of more exponentially. Certainly, we can see at the moment that there are significant delays in getting midwives endorsed, and that's because of the number of midwives that are applying. So they're out there, they're getting out there, and it's, it will improve. To be honest though, like a 6-month course for prescribing is not a really big deal. Yeah, the 5,000 hours takes about 3 years to undertake in terms of clinical practice, but 3 years in a 6-month prescribing course is not an insurmountable hurdle. One of the more insurmountable hurdles, which we're seeing as becoming more and more and more problematic, is the issue of insurance. And look, this is one of those things that I said Sue and I have debated for about, God, 2 years or something. And the complexities around this issue are quite significant. But I guess the main take-home message is that where there are significant and high claims of, say, between 2 and 20 million, and certainly over 20 million, even with the existing models of insurance and organisations being able to purchase insurance, there still is a degree of risk for the organisation. So it's something that needs to be resolved. I don't think it's something that I need to dwell on, but I guess it's still there as being a bit of a problem. The other thing is this question of women being admitted as private versus public patients. And women are in the models that we're looking at, where the Aboriginal Community Controlled Health Organisation employs the midwife, or an organisation like My Midwives employs the midwife, the women do need to be admitted as private patients for their insurance to cover that admission. So this means that the hospital actually needs to waive the bed fee for the woman to be admitted, so that the woman isn't charged. Now, there's a bit of conjecture at the moment around the cost, and Sue and Yvette are doing a costing analysis, or a much more robust costing analysis at the moment. I guess the thing that's interesting for me is that there are models where hospitals are waiving bed fees without any concern at all, and even not just in Queensland, but in Victoria. And there's also some other benefits that the hospital receives, which is that they don't need to staff the care of the woman. So the staffing arrangement is much more fluid. So even possibly more fluid than with an MGP, because you've got midwives sort of coming in and out all of the time. You don't actually, the hospital doesn't have to think about staffing at all. It is completely based on the needs of the woman and the needs of that woman when she presents to hospital. The hospital can also generate any Medicare funding for the services it provides as the woman is private. So things like pathology, radiology, and medical attendances. The hospitals are saying that that's not a very large factor, and I would say that that is probably, there's probably difference of opinion around that. Certainly we've been doing it for 12 years here and have had significant amounts of bed fees being waived, and the hospital is indicating that they've come out in the positive. But at the moment, the Northern Territory are having a bit of trouble with coming to grips with how the funding might work for the organisations. The other thing that's interesting in this is that in some areas, hospital visiting access is seen as not being a problem at all, whereas in other areas, it feels like the sky is going to fall in if the midwives are actually admitting women. And I guess if we look at the two jurisdictions to just compare 12 years, Queensland, where it is normal business, there's been 4,100 Medicare rebated births. And in South Australia, for example, where it is a sky falling in type prospect, there's been 19 births. So we can see that this is something that we need, again, a little bit of direction and leadership at a government and health service level. So what's next? I guess that my big view, I say for every woman, we need to have midwifery continuity of care. This slide says that we need birthing on country for every First Nations woman by, or family by. And I guess that is the $1 million question. There's definitely a roadmap that's under development by CDU that is bringing in that concept. But it does require effective change. It requires a lot of leadership from a lot of different people and different organisations. And look, this is only one way to do it. The use of endorsed midwives is only one option. There's many, many other options to provide continuity of midwifery care. And there's many things that you can do to maximise and offer absolutely exemplary care for women. But I think that we all need to look at what parts we can play in that conversation and what we can actually impact in that change. Obviously, CDU team and many, many others are looking at the expansion of different options and are also looking at developing a toolkit to provide different organisations that might be interested at all stages of development, some of the little tips and tools that we can use to actually help them with making those changes. We also need government to come back together and look at some of the barriers, and particularly insurance is one that we need to target at the moment. But the funding and Medicare also needs, some action from government to make sure that we can make these models completely sustainable. So I think that is my last slide. So I'm happy to have questions and answer questions. Do one of you guys want to look at the chat or something for me, or do you want me to get on the chat, or what do you want me to do? You'll look at the chat.
Sorry, I'm happy to look at the chat, but Brett has put a very long question there, so I might just ask Brett to come and if you're able to put your microphone on, Brett, it might be easier if you can actually speak to your question. And if anyone else has got a question, if you could just pop it in the chat. I'll try and keep an eye on that while Brett's talking about his question, if you're there, Brett.
I am indeed, and thanks for the opportunity, and really appreciate this presentation, webinar. Yes, it was just reflecting on the level of intensity of the support that was provided in the case example, and I was reflecting on the fact that I just put in a submission to the inquiry that's happening in this state on child development services. And I wanted to see, well, they asked the question in the inquiry as to what services are provided elsewhere in the world that we might want to consider. So I've just cut and paste what's happened in Sweden. I don't know if you want me to read it out or...
no, read it out. I think that'd be great.
Where it says preventative care is carried out at midwife-led maternity health services, nurse-led child health centres, and nurse-led school healthcare settings, and reach almost everyone, 99% of the population of kids in Sweden. All healthcare for children and adolescents is free up to the age of 18. Although the Swedish system has an implemented approach that emphasises health promotion and prevention, health monitoring is still a central task. During the first 18 months of a child's life, the families have at least 11 scheduled routine health visits. The nurses participate in all the visits, and the physicians participate in 3. The children undergo 5 developmental checkups performed by either the nurse or the physician, and 3 medical examinations performed by the physician. So that's what's standard in Sweden. So I just thought it was interesting to compare that with the intense support that was obviously required in the case example. But in fact,
the case example, those postnatal visits, it was almost like it could have been provided in a different way, in a different model, but it was more almost like a live-in, not even live-in, but like a very constant service just for the first sort of 4 to 6 weeks. So after that, in the first 4 weeks, it was really, in the last 2 weeks before the transition to child health, there was just the normal sort of a normal weekly post, I think twice weekly in the 5th week, and then weekly after that. And then once they've made the transition to child health, they've actually just followed a fairly standard child health pathway with integration between their GP, who was absolutely exceptional as well, and the child health services, and then regular community days. So those pictures are just with the family dropping into community day and participating in the various activities that are available to them. So whilst the first part of it was enormously intensive, the the learning and teaching that went as a part of that in terms of the transition into mothering really set them up for that next period of time. Obviously, we wouldn't be doing that for every single family, but that is just one example of where the benefits, I think, outweighed by far the intensity that was required for that family.
Yeah, Liz, I'll just jump in and add something to that as well. I think I've just put an address there in a link to an article in the chat. I mean, the Birthing in Our Community program, somebody asked, is there an NGO or government? It's actually run by the Aboriginal Community Controlled Health Organisation, which is the Institute for Urban Indigenous Health. So that would count as an NGO, not government. And it's been fairly very well evaluated over the 10 years that it's been running. And the link that I've put in the chat there is a paper that came out 2 weeks ago that showed that a very, very in-depth costing of this model was done. And it showed that not only did it reduce preterm birth, but that it was cost effective. So it saved $4,810 per mother, infant, baby. But it also reduced the cost to the family, to the mother, by 2/3. So it brought the service closer to home, closer to mum, and saving money for the family, which is really important. We have another paper that's under review at the moment, and it showed that the model did reduce unborn notifications and babies being removed at birth, which is pretty stunning. It was small numbers. But that case study that Liz explained is the sort of thing that we were seeing enough to show that there was a statistically significant reduction in unborn notification and child removals in the Birthing in Our Community project. So that data will come out soon as well. So you can see that even though it looks like a really intensive program, the cost effectiveness is sound. It reduces the birth interventions, it reduces the numbers of babies admitted to neonatal nursery, and it reduces things like, big ticket items like preterm birth. I'll put the link to that article in as well for you. But it's these other things, you just can't put a price on a mother and partner, in this instance, going home with their baby. And keeping that baby together and having the support to do that, that's just priceless. I mean, of course, we can cost it, but it's still, every one of us listening to this seminar would know how important an outcome like that is. And you can see how important it is that this model does get rolled out to people across the country as we try, so many different ways of, getting around the legislation, getting around the regulations, trying to push pressure on the states and territories and local hospitals to come on board, and helping build the capacity across the Aboriginal community controlled health sector and the midwifery workforce so that people can work in this way. Do we have any more chats? It doesn't look like there's any more questions. Liz, was there anything else?
No, I think that probably I was going to, I don't know whether we put no, we haven't. This last slide had all of the different resources, which is the studies that Sue's referred to that basically have come out of the Birthing in Our Community model on the south side, really, at this point. None of our data, we've only been up in North Brisbane for 2 years, so we still are in our very early days up there. But obviously the work on the south side has been well published, as Sue's indicated. So I have got a list of those references if you need them circulated to you.
Liz, you're on the thank you slide there. Did you have a slide with all the references?
I did have another slide, but
it's okay if you don't. If it's
no, I don't think it's been included in this one. Sorry, Sue, but I can send it around. Yeah.
I've put the link to 2 of the key articles in the chat. And this will be saved. We save all of our presentations for the Centre for Research Excellence on Birthing on Country with Professor Yvette Rowe is the lead investigator on that, and all of our seminars are saved on the website. So I put a link to that earlier in the chat as well for people. There's quite a few other seminars there. Is there anything you wanted to say, Yvette, before we wrap up, unless there's any other questions?
Thanks a lot, Liz, again for coming to the party and sharing your wisdom. And I think you've sort of touched on it about coming into such an interesting space, that working in this Aboriginal and Torres Strait Islander space, which I think as a business model, and also your colleagues there's been a huge transition and growth. And sometimes we talk about the inequities and with our population. So to having you as an ally and a specialist to come in this field is really important. And I think Liz's presentation talks about, is really important about how we need allies who bring specialised skills, but are so mother and baby family focused. So thanks, Liz, for your contribution, and I'm sure that the participants in there would really like to extend their appreciation as well.
Thanks. No worries, Yvette. That's great.
I might just ask one more question before we do go. I can see that there's a man in that photo. So you want to make a comment on the role of IU has obviously got a man to support the program. How does that work?
We've actually got two men now. We've got so the man in that particular photo is Dave, who's a social worker, and Dave works with the dads and is really supportive around developing the role of fathers, and so he spends a lot of time not only one-on-one but working with the dads. And we've also got Dan, who's one of our male midwives from our core model, who's doing antenatal and newborn care workshops with the dads in the program, which has been absolutely fantastically well received to just grow the work that goes on. We do so much with the mums that transitioning for the dads has been just such a big gap, really. So having two men involved, kind of a little bit off to the side, but still part of the overall model, has been absolutely fantastic. Poor Dave runs between north side and south side now, and I think they're trying to co-opt Dan to go over and do the same thing on the south side as well. So we could have them both doing a little bit of a tag team across from north to south. But it's been a great additions to the model.
All right. Well, thank you, Liz, and lovely to see some beautiful messages in the chat. Thanking you, Liz, and appreciating you sharing your knowledge. Thank you, everyone, for joining us. And keep an eye on the Centre for Research Excellence website and mailing list if you're not already on it. Please write to us and add your name to it. There's monthly seminars where we're sharing the knowledge on how to continue to build birthing on country services across the country. Thanks everyone for joining.